So in that case, I'm gonna talk into, oh my goodness, and turn out of, okay. How does this sound? Are we getting things? Yes. How's that? That didn't change anything? Oh. Okay, trying to figure out what to, okay, great.
So, Norma, does that sound okay to you? Okay. So maybe if you could, whatever the last thing you want, take it down just a titch.
Okay.
Or you can turn it down here, but it's better if. Cool. So now when you have good levels, you should have good levels.
Awesome.
Cool. Can I help, like podium mic check, lavalier mic check?
I think the podium mic is off right now. I didn't know they were bringing their own laptop, so that's cool. But yeah, if you want to just turn the podium mic on,
Okay. How do I do that?
because it's like it's all
Is
unmuted and ready to go, but it's just off.
Okay. How do I turn it on? Is
There's
it
like a
switch?
button. Yes, like at the base
At the
of
base?
the mic.
Oh.
Yeah.
Okay. Cool.
There'll be a little green light.
So, yeah, you know, the email.
Sweet. Thank you. The iPad helps a lot. Testing this mic. Hello. What do I do? Hello. 1, 2, 3. Oh, sorry. Check, testing this mic. 1, 2, 3. Mic check. Okay. Hello. she was very nervous.
And there was my stuff.
And there was mine.
Thank you.
Absolutely, thank you.
Oh, you're welcome. Are they even using a stick mic?
We will use them
Okay.
for question and answer. Then we have a panel portion.
Do you guys want one of them here?
Oh, that
or-
one. Sorry, no, we won't use that. Just
Okay,
this.
I didn't
Sorry.
think so, but
No, we
yeah.
could
So I'll
take
take it
that off.
away. And then we have a laptop requested,
Okay.
and so I have one in the back. Do you guys
Perfect.
want to use ours, or will you need it
Just
later?
on standby
Awesome. Well, it is on standby.
in case we run into problems. So that'd be
Yeah. Yeah, we got that. Awesome.
Yeah. Cool. Thank you so much.
Absolutely.
Thank you guys.
Yeah.
Thank you. Thank you. Well, welcome everybody. We're thrilled to have you out and here at the 10th Annual Family Matters Conference presented by Call to Action Philanthropies. And we're grateful for their sponsorship that allows us to be here and our other sponsors as well. You'll learn more about them at lunchtime. And we appreciate everybody coming and being here. My name's Brad Simps. I'm the director of the Bachelor of Social Work program. This conference is in connection with the College of Education and Family Life and Human Development, and we're grateful for that relationship. We will recognize, she may or may not like this, but we'll recognize our Dean, Dean Pan Pal. If she wants to stand up, we'll give her a round of applause for her support. And we're grateful for her and for all our volunteers. Really, we have many volunteers helping to make this happen, and we're appreciative of them. I'm honored to be able to introduce our first speaker, Annie Deming. She has over 20 years of clinical experience and has been licensed as a psychologist since 2010. She said, Utah became my home after being matched for a psychology internship at Primary Children's Center for Safe and Healthy Families. She completed her postdoctoral fellowship at Huntsman Mental Health Institute, which was previously the Neuropsychiatric Institute. And then her job at Primary Children's Wasatch Canyon's Behavioral Health Campus began in 2010. She became the Wasatch Canyon's, or the clinical director of the Pediatric Behavioral Health Service line in 2022, and she values multidisciplinary collaboration and has helped their outpatient clinic transition to a team-based approach. She's also now the clinical director for pediatric health at Primary Children's, and we're really honored to have her. Her topic is being trauma-informed, and I know we're in for a treat and appreciate her being here with us. So we'll let Dr. Deming take it away.
Thank you, Brad. Okay, can you guys hear me okay with the lapel mic? Okay, I'm gonna try not to hit it and make it noisy. Okay, so yes, like Brad said, I'm talking about being trauma-informed today. And I think that means a lot of, let's see, should we turn this off, maybe? Okay, is that better? No, okay, I will walk away. Okay, sorry, I don't know if maybe that's better if I stay here. Okay, thank you. All right, so being trauma-informed means a lot of different things. To start off with, I just want to let you guys know I'm coming to you first and foremost as just a fellow person, someone who's been really interested in behavior my whole life. And then secondly, I'm coming to you as a psychologist. And that's very important to me. I'm very passionate about my profession, and I believe that psychology and similar professions like social work, we really have a role to play in making our world a better place. So that's kind of the second reason I'm coming to you. The third reason is as a trauma therapist. So like Brad mentioned, I did my psychology internship, which is your last year of training as a psychologist at the Center for Safe and Healthy Families at Primary Children's. And I matched there, so you don't necessarily get a whole lot of choice when you match for an internship. I did not rank Safe and Healthy Families first. I did not want to be a trauma therapist. That was not my future, I thought, in psychology. In fact, in graduate school, when other people were interested in trauma, I was like, I don't know why you like that. I'm going to focus over here on behavior. I really wanted to understand oppositional behavior, conduct problems, and antisocial behavior. And I laugh at myself now because what I understood very quickly when I started becoming a trauma therapist is everybody has a story. Everybody has a reason to do what they do. And so our diagnoses, and psychologists, we're steeped in diagnosis. That is our thing. We are the best at it, I would say, in our professional world because we have such deep training. It doesn't mean we're always good at it, but our training really gives us the underpinnings for that. So as I was thinking through behavior, diagnostics, and then I became a trauma therapist by accident, I got a lot of great training at Safe and Healthy Families. I was like, wow, this is a huge, huge problem, a huge new world. And we don't have these diagnoses that really support our kids to understand what's going on with them. And our diagnoses like ODD, like conduct disorder, these are not good descriptors of why kids do what they do. So then I started this process of this idea of being trauma-informed. What that means to me is that we understand why behaviors happen. It's not necessarily that we have to dig in and know exactly what has happened with a patient, but we do have to understand why they're doing what they're doing. So that's what it means to me. All right. Okay, so today we're going to talk about a few different things. I want to kind of give you a window into how I believe trauma should be conceptualized and then what we should do about it. So I'm going to talk a lot about how trauma impacts development. I'm also going to talk about the conceptualization of trauma and how I think it contributes to psychopathology. And not just I think, I keep saying that, but this is research-based, I promise. It's not just my thoughts up here. We also will talk about the links between attachment, trauma, and personality development. I think that's important to understand not only as practitioners, but as researchers, as public health people, as family members. It's just very important to understand these links. And then I'll talk about some trauma-informed tips. What does it mean to really act and be a trauma-informed clinician or just a trauma-informed person? And feel free to ask questions. I can see everybody, so if you have questions, raise your hand, stand up. I would like this to be more interactive if possible. All right, so what is trauma? So it's important to understand that trauma is a deeply distressing or disturbing experience. And people try to identify like specific things that are traumatic, but it really isn't our right as professionals to identify something as traumatic or not for somebody. They get to decide that. They get to determine whether or not something was traumatic for them. So it's a distressing or disturbing experience that someone has had. It's also inevitable and universal. So trauma occurs across the world. It occurs in the developed world, the developing world, everything in between. It's almost an inevitable experience of being human to have some sort of traumatic experience in our life. If it's not addressed, if trauma is kind of pushed away, not dealt with, not talked about, it really can result in tons of mental health issues, physical problems, behavioral problems, and relationship issues. So the good news there is that if we do address it, we can move forward in a positive way. Oh, and I should mention, the beginning of my talk is really depressing. We just need to accept it for a minute. It'll get better, I promise. But we're going to start with kind of the research about how trauma really impacts things. And I don't mean to be depressing or negative, but my point is, let's understand this. We often talk a lot about behaviors and why people do what they do, but I don't think we often understand the why, the actual why. And when we don't understand things, we tend to equate behavior with bad. People are bad. This behavior is a challenge. I can't handle this, maybe as a parent. My child is doing bad things. But when we understand the why, we can reframe that, and that's very important. All right, and then it can be intergenerational, and I kind of chuckle because good therapists have known about intergenerational transmission of trauma for years, but the science is only now catching up. And I have a slide later where I talk a little bit about epigenetics, and finally the science is catching up to what we've known all the time. So good therapists have understood that trauma can be passed through generations. Our science, the only thing our science used to say is it's parenting style, or really poor parenting is what passes on trauma from generations. And again, good therapist was like, no, there's something else going on. And now we know all of this stuff about epigenetics, which is super exciting. So it's important to understand trauma can be intergenerational, can literally be passed down in how genes are expressing themselves. Okay, so the more positive side of this is if trauma and its impacts are addressed, there can be positive outcomes. So one of the things that I feel very honored about in my professional life is I've been able to walk along the path with lots of children and families who have been traumatized. And I feel a deep honor about that. It is so painful when kids and families go through trauma, whether that's kind of what EMDR calls big T traumas or even a series of little t traumas. That's a really serious event or a series of events in children's lives. And I've been able to join them on their path and try to help them walk that a bit easier. And I've seen it work. I've seen trauma therapy work. I've seen kids get better. I've seen families heal. I've seen them get stronger. So it can absolutely be addressed. But again, that first key piece is that we have to understand it, and we have to know that it's driving behavior. Okay, so similar to what I said before, trauma is the experience rather than the exposure. So there are people out there who have been exposed to trauma of any kind, some kind, lots of different things, and they don't have trauma symptoms as a result. Now, there is a lot of science trying to define why and describe why that might happen. We know a little bit, so there's a lot of resiliency research, and so we know that, okay, there's something there, but we don't really understand all of the reasons why some people react really strongly to a traumatic event and some people don't. But we have to understand that. So even though someone's been exposed, doesn't mean that they're going to react in a certain way or going to have symptoms, but they often do. So the experience of that person is very important to understand to figure out how they will be impacted. All right, so I'm going to talk about the ACEs study. And I know this is very commonly understood and known, but I'm going to go at it a bit a different lens. I don't know, most people don't necessarily understand or have heard about the history of the ACEs study. So if you have, I apologize, but I find it fascinating and I love talking about it. So our study of adverse childhood experiences started from a doctor who was studying and treating patients with obesity. So he built this lovely program, weight loss, really felt like, okay, I know what I'm doing, I know this is gonna work. And he kind of worked with all of his patients, set them up on a specific program, and 50% of those patients dropped out. And we're like, no, we're not doing this. I can't do it, I can't make it. Even if they were succeeding, the success was defined as weight loss. So even if they were losing weight, and from his perspective, they were succeeding, half of them dropped out. And he got really fascinated about this. Why are they dropping out? So he started to ask questions and kind of felt like, okay, maybe I'm missing something in development, but his mind wasn't yet on trauma. It wasn't there yet. But okay, let's figure out what maybe led to the obesity as far as physical health, like what their habits were with eating, how old they were when they weighed certain amounts of weight. So he kind of had a developmental lens, but it wasn't trauma related yet. So he was asking questions about kind of like how much you weighed at a certain age. So how much did you weigh when you started school? How much did you weigh when you started high school? All of these things. And one of his questions, which is just a common question doctors ask their patients, is how old were you when you first became sexually active? he messed up on a question. He was tired, and he combined two questions. And he said, how much did you weigh when you were first sexually active? And the woman that he was interviewing, he made a mistake. He asked the question the wrong way. She said, I was 40 pounds. And he was like, what? And asked again. She said, I was 40 pounds and I was 4 years old. And it was my father. So it was this like wide awakening for him. And he started asking her more questions. And in fact, she had been sexually abused for years and years. And she started talking about how that affected her eating habits, her health habits, and led to her obesity. So then he started thinking, I wonder if these other folks who have dropped out of my lovely weight management program have the same experience. So he started interviewing all of these people, mainly women, and he found some crazy high percentage were experiencing or had experienced sexual abuse in particular, but also other types of abuse. And then he got really like nervous, like, okay, maybe some sort of bias is at play here. So he had colleagues go interview. He's like, maybe it's just me, how I'm asking the questions. He asked 5 colleagues to go start interviewing people, and those 5 colleagues found the same thing. So that's really what sparked the ACEs study, and I love sharing the history because it's so important to understand that some of these things that almost seem commonplace now, that yes, childhood experiences impact our current health, we didn't used to understand that. Again, good therapists, I think we've been ahead of the curve for a long time. People should listen to us, generally. But where we're at now, the science is catching up with all of the things that good therapists have known for a long time. Okay, so I won't go into a lot of the details. You guys can probably have read a little bit of this slide. But we have this nice long list of ACEs now, and we can get ACEs scores and things like that. But the point really is early childhood experiences affect our later life. There's a couple of interesting details that I think are important to mention. So just folks who were asked about trauma, just by asking, not even offering resources, not even going to trauma therapy, but just by asking the questions about trauma, it reduced doctor's office visits by 35%. So this is that role of avoidance. As soon as someone was able to say, yes, this happened to me, then people got better, just kind of automatically. So that's another reason we really need to focus on, let's dig in, let's figure out why you're doing what you're doing so we can help you heal from that. Also, emergency room visits decreased by 11%. So many people in this study, tens of thousands of people now, they've enrolled more. And it was just kind of this groundbreaking idea because the initial population of the study were generally kind of middle-class working Americans. They had insurance, so a fairly privileged population. Most of them were housed. I mean, this was a population that we might not on the outset assume that they'd had a lot of trauma, but most of them did. Okay, I'm gonna show this pyramid. So it's been added to over the years, and I found this one actually just yesterday. And I love that it includes the generational embodiment of historical trauma, and I'll talk a little bit more about that in a minute. So we have this kind of bottom of the foundation that we're being raised in, we're growing up in, and there is historical trauma out there for kind of all of us in some way. And then there are some racial and ethnic groups that have kind of disproportional historical trauma. And so that's an important piece to understand. And then there's a lot of social conditions, there's a local context that you're being raised in. And then if you have adverse childhood experiences, it leads to disrupted neurodevelopment. And then after that, social, emotional, and cognitive impairment. After that, adoption of health risk behaviors like smoking, poor eating habits or unhealthy eating habits, drug use, alcohol use, all of these things. Then it leads to disease, disability, and social problems, and then early death. Again, this is way depressing. I apologize for that. But again, we can intervene at every level here, which is important to understand as well. Okay. So shifting a little bit more specifically to some stats about childhood trauma. Again, very common, universal. There's several studies that have tried to look at the prevalence of trauma, and they hover between kind of 30 to 70%, and that's a wide range, but even 30% is a very high number, right? Almost 1 in 3 kids might be exposed to trauma. And most of the studies are kind of on the higher end. So 68% is one of the higher end, but like I said, it's still very common. So regarding diagnosis, our trauma diagnoses are poor. Don't get me started on the DSM. As a psychologist, I'm probably the biggest person to complain about the DSM. So yeah, we won't get into that today. I can talk about that another time if interesting. But our PTSD diagnosis criteria for kids in particular is very poor. Regardless, though, when we look at PTSD actual diagnosis and meeting criteria for that, a PTSD experience is not quite as common as post-traumatic stress. So even if they don't meet criteria for the diagnosis, there is still stress after trauma. Our risk factors for post-traumatic stress are kind of interesting. So past traumas, so if you, just like our ACEs study shows, if you have past traumas, you're more likely to have post-traumatic stress. If you have a history of anxiety, that rises to the top kind of over and over in research. A history of anxiety leads to more traumatic stress responses. Also, I'm going to skip this older one. This is actually not bearing out in the research anymore because we know, similar to what we're noticing with brain injury research. So when I was in school, we used to learn if you have a brain injury earlier in life, it's better because then you have more time for your brain to heal and kind of come back from that. That has switched over the last 15 years. That is no longer true. Brain injuries later in life, after skills have been established, are actually less impactful than they are when you're young, especially severe brain injuries. And trauma is showing the same pattern. So it's not that older people or older kiddos exposed to trauma do better. It's that if they're younger, they tend to do worse. I said that backwards. If they're younger, they tend to do worse. If they're older, they tend to do better. Because that early time in life is where brain development happens. The biggest time of our life where our brain is growing and developing and we're doing all this pruning of brain cells and pathway development. When that's disrupted early, that's when we're seeing the toughest outcomes. And then the other thing to keep in mind about that is our trauma treatments are not as good at getting back into that earlier trauma. EMDR is probably the only one that's really showing some good evidence. And then there's also child-parent psychotherapy, which is really focused on younger kids, and that's showing some good evidence of recovery from trauma. But the reason it's showing that is it's healing the attachment between parent and child. Okay, so we also know that an adverse family environment, so chaos in the family, parents with mental health conditions, all of our social determinants of health, if those are a struggle, then kids are more apt to have post-traumatic stress. All right, so again, the psychologist in the room is going to talk a lot about diagnosis. So depression and anxiety are both risk factors and sequelae of trauma. So if you have depression and anxiety before, and then you have a trauma, your depression and anxiety is likely to worsen. That's also true in brain injury, very interestingly. So if you have a concussion and you have pre-existing depression and anxiety, it's likely to worsen that depression and anxiety. So keep this in mind, this connection between brain injury and trauma, because there are parallels. Again, anxiety history, highly predictive. In those with post-traumatic stress, the rates of depression and anxiety increase the most. It's important to understand. And then kids who have been exposed to trauma tend to numb their emotions. You cannot pick and choose what emotions to numb. You can't do it. So when they're numbing their sadness or anxiety, they're also numbing their happiness and joy. So for those of you who work with individuals who have been exposed to trauma, they're often pretty flat, blah. And then they vacillate also between kind of what in the EMDR world we call hyporeactivity and hyperreactivity. They bounce back and forth from that. So that numbing, that experience of joy just really gets impacted. Okay, so let's talk about neurobiological effects. So we've done studies on brains, we've done studies on stress response, all of this. Neurobiological effects in trauma tend to be pretty inconsistent and unpredictable. That makes a lot of sense, right? Because people who have been exposed to trauma, their behaviors tend to be pretty inconsistent and pretty unpredictable in general. And it's because the stress response is uneven and it's inconsistent. It doesn't act the way it should. So when our stress spikes, our cortisol spikes, we're supposed to probably seek calm and protection. People who are exposed to trauma do that sometimes and don't do that others. So all of this inconsistency and chaos kind of ensues within the brain and the body. We also see lower cerebral volume, lower brain volume. So your brain is not growing the way it should, is the basic take-home point there. Also smaller corpus callosum, so our connectivity between our left and our right brain tends to be smaller in those who have been exposed to trauma. So you're not integrating, is kind of what we would say in therapy language. There's also less asymmetry of the prefrontal cortex. So asymmetry in our prefrontal cortex is good because we have different sort of areas that drive different things. So kind of the idea of left brain, right brain. So we want that asymmetry. Kids who have been exposed to trauma have less of that asymmetry. And then this finding is specifically in orphanage-raised children. There's a larger amygdala volume. So your fear center of your brain tends to be overactive. Okay. So let's talk about trauma and diverse populations. This is an important area to understand. That bottom area of the pyramid, which was that kind of historical context and our ecological context, is important to understand this kind of passing down from generations. So race is not, a biological issue. We don't have different biology based on race. So race is a sociopolitical categorization that has been used to differentiate groups based on phenotypical characteristics. So phenotype is what we show on the outside. So race is this social construct that's been defined to try to categorize and differentiate people. It's important to understand that. Youth of color, in particular, report greater exposure to trauma. So more commonly, they have exposure to trauma, especially Black and Latinx youth. There's also a role of racial stress here, and that shows up in a few different ways. So even if kids, and this happens in adults as well, are not directly exposed to the trauma, if they see things on the media, on the news, that their racial or ethnic group is being targeted and there's been some sort of racial attack, that's traumatizing in and of itself. They wouldn't necessarily, this is the problem with our diagnostic system, they wouldn't necessarily then be qualified for a diagnosis of PTSD because they have not been exposed to what we call a criterion A event, one of those events that the DSM decides is traumatic or not. However, it still can cause post-traumatic stress, important to understand. In some studies, it's as high as 90% of Black youth experience some form of racial discrimination by age 8, and again, this can be direct or observed. Also, trauma may be more disabling for youth of color given other traumatic experiences. So racial discrimination is only recently kind of being thought of as an adverse childhood experience. It's only recently coming into our official trauma measures that we use in psychology, but racial discrimination is certainly a traumatic stressor. And so those things might be overlooked. So it's important, again, to understand the social context that our kids are being raised in, and kids of color are having more negative experiences than kids who are not of color. All right, so racial stress alone, again, this would not qualify for a trauma diagnosis, but racial stress alone can lead to substance use, conduct problems, big asterisks on that for just a second, trauma symptoms, and then psychological symptoms such as the internalization of racist beliefs that devalue the self. And that's huge. So, I've heard at times, and I'm not hearing this quite as much anymore, which is a good thing, but I've heard at times, why, you didn't experience that. Why are you feeling upset about that situation? And it's because they've internalized this idea of racial stress. They've internalized there's something wrong with my race, or there's something wrong with my ethnicity. And then that leads to negative core beliefs, which, again, trauma related. Okay, again, the exposure does not have to be direct. Historical and cultural trauma can also be passed down both through social, so kind of the social context of what we're doing, and then epigenetic mechanisms, so how your genes are expressed that have been passed down from generations. Racial stress can also impact parenting and secure attachment, and there's often communal trauma responses. So if there's some sort of trauma occurring, it does not just impact one family, it tends to impact more than just that family directly. It's good to note that teachers, schools, parents, communities, everybody in this room can be very protective as well. If we can work on setting up a social context that's kinder, more compassionate, curious rather than judgmental, all of these things can really have ripple impacts for positive effects, trauma in general and certainly trauma and diverse populations. Okay, let me talk about the diagnosis of conduct disorder for a second. So I have the opportunity to train a lot of up-and-coming psychologists. I supervise a lot in my job, and it's probably one of the highlights of my career. I always teach my psychology students, I will not see a diagnosis of conduct disorder on a report, a psych report, ever. If I see it, you will be in trouble. Like, it's just not an appropriate diagnosis. Now, the reason for this is kind of the point of my whole talk. We have to dig underneath that behavior. Again, everybody has a story. So conduct problems like lying, stealing, truancy, delinquency, all of these things that we see in individuals with conduct disorder, and by the way, males of color, in particular black males, are disproportionately diagnosed with conduct disorder and placed into the juvenile justice system, despite the fact of all of the data I just presented about racial stress, despite the fact that there's a lot of trauma in that population, despite the fact that they need treatment, right? They need help, but they are put into the juvenile justice system with a diagnosis of conduct disorder. I see it over and over, not from my psychologists, but from a lot of other groups. So if you see that on a report, or if you're led to make a conduct disorder diagnosis, please pause. Please try to understand what is driving those behaviors. And similar with ODD, by the way, oppositional defiant disorder, similar in my book, we have to define and describe and understand what is driving those behaviors. There's always a reason. If you haven't found it, it's just because you haven't found it. If you're like, I don't know why they're acting that way, they're just behaving, no. If there's not a reason in your face, it's just because you haven't found it yet. Keep looking. Okay, sorry, that's a bit of a soapbox. I will move on. Okay. So this is a great model of epigenetic vulnerability from historical trauma is kind of where we start. And this is specifically about racial stress and racial trauma, but this is a wonderful framework that we can apply to just childhood trauma in general. So there's this epigenetic vulnerability from historical trauma, past experiences, back generations, and then there's an event. It's a racist event or a traumatic event. Then there's your individual traumatic reaction. There's family processes and contexts that impact that. There's also community processes and contexts that impact that for positive or negative, by the way. And then we have symptomatology. And then we have all of our PTSD symptoms. So re-experiencing, intrusive thoughts, avoidance, negative mood and cognitions, and then psychological arousal. So this model is just kind of, this is how I try to approach psychological assessment. Figure out, okay, what events have driven these symptoms? And if you notice, I also love where we can do prevention and intervention. We can't really do anything to prevent historical trauma. It has happened. However, we can create the society of support, and we can prevent traumatic events from happening. We can also intervene after they do. So there's lots of hope. Yes, is there a question in the back? Yeah.
Can you speak to the interaction between early childhood trauma and developmental age?
Yes, do you mean specifically when trauma happens? Oh, do you mean different than chronological age? Yes, yeah, that's a great point. So kind of this idea of intersectionality, right? So if somebody is, oh yeah, there you go. Do you want both of them? Okay. If somebody is, has a different developmental age than their chronological age. So for example, if someone has intellectual disability, we know that individuals with intellectual disability are more vulnerable to trauma and being taken advantage of. And so you have to understand from, okay, a developmental lens, if their developmental age is lower, let's say, than their chronological age, your interventions have to better match where their development is. So that's very important to understand that context. It can also be quite impactful as far as verbal skills. Like if a kiddo has lower verbal skills, it's more difficult to do that trauma treatment. And so it can lead to behaviors that are maybe more significant at times. So that is also important, yes, to understand. Yeah? Good question. Yes, the answer is yes. The complexities there are, it tends to be uneven. So it impacts some processes and not others. And I will talk a little bit about that in a minute, actually, kind of the differential effects. Thanks for the question. Sorry you had to like dance and wave to get my attention. Okay, actually, it's this next slide. Okay, effects on cognitive scores. Okay, again, the psychologist in the room is going to talk about IQ testing. So generally, higher verbal intelligence overall, or higher IQ overall, tends to be protective. So that's kind of getting back to the person's question back here. Generally, if you're more advanced developmentally, if you're brighter, more intelligent, you tend to go through trauma a bit better. Not across the board, but certainly it's a protective factor. However, when people experience trauma, they tend to have a lower verbal and performance IQ than they might have. So yes, it can really impact your brain development in that way. We see lower scores across the board in all areas of people diagnosed with PTSD. Sexual trauma tends to affect working memory and visual, spatial abilities. Interesting. Attachment trauma impacts kind of everything. Not so much verbal IQ. Your verbal skills tend to be pretty solid, not as impacted as other things. Survival trauma, meaning, like if you were in a car wreck and someone died and you didn't, that affects your processing speed. We also see some positive impacts of trauma on occasion. So children who have been divorced tend to have better working memory. And the reason, we think, is because they have to keep track of their stuff across two households, right? They have to remember, oh, I have to take, this stuff to dad's, I have to take this stuff to mom's. It does improve their working memory. Also, their processing speed tends to get better. Not across the board, but overall. Also, having a parent exposed to war, but if you weren't specifically exposed to that, there's some positive impact on cognition. We don't understand that fully. It's likely, the child didn't experience things directly, and kind of this idea of a parent being able to survive, but those are just hypotheses. We don't really understand. That. There can be a positive impact of numbing. So let's say someone has a single trauma, they numb for a period of time, that can be protective. Except if it lasts too long, that's when it gets kind of bad. Okay, so just to kind of summarize, trauma has cumulative effects. We have a lot of hyperreactivity, so over-arousal. We have a lot of hyporeactivity. People with trauma tend to bounce back and forth across those two dimensions. Generally, if someone has a shy or inhibited temperament, they have a higher likelihood of anxiety and depression post-trauma. Partly that's because they're not as likely to reach out for support. When we have trauma, we need connection. We need to feel healed kind of within our social network. And then we also know that disturbances in supportive care, so if families are struggling to cope with the trauma, that can really rob children of an effective buffer. So the family unit, and in particular primary attachment relationships with parents, have the most power to heal kids from trauma. So when that's disrupted, that can be very traumatic additionally. All right, so I just want to think about this statement here, because I think it's important to understand. So chronic elevations of stress hormones can affect synaptic connectivity, so brain cell connectivity, and neurogenesis, brain cell growth, and it can increase cellular death. So back in the 80s, we had all these public service announcements about, how drugs kill brain cells. We need to have public service announcements about how trauma can kill brain cells, because it certainly can. So trauma effectively alters the typical pathways and organization of the young brain. So if you take nothing else away from this talk today, please take away trauma impacts brain development. And then that brain development impacts behavior. So again, the why, right? We have to figure out, okay, what's going on with this behavior, and the why is often trauma. Okay, so I want to help everybody really kind of think through this idea of trauma and developing psychopathology. So we've touched on this, but we have some really good treatments in our mental health world that really help us conceptualize this. So the idea of DBT and biosocial theory. So DBT teaches us that people come into the world and have stronger emotions, they have a harder time regulating those emotions, and they have a slower return to calm after emotions have been triggered. That's the biological part of DBT. And then the social theory is that there's some sort of invalidating environment that has occurred. Trauma is one of those things. So even if it doesn't happen within your family, trauma does feel very invalidating generally. So then we have these symptoms of self-harm, suicidal behaviors, all of this stuff. DBT kind of has it right as far as how we conceptualize trauma. EMDR as well, I think, has this right. So this idea of the past is the present. Things that we have experienced in our past affect our behaviors today. And it might be big T traumas, it might be little t traumas. So that's important to understand that it really does impact our present behavior. So trauma really does lead to this altering of brain development. And then we have chronic emotional dysregulation. This is why we have, okay, this is my hypothesis. This is why we have so many diagnoses of ADHD. The ADHD is a thing, I promise. It's out there. Lots of people have it. But we also have inaccurate diagnoses of ADHD because we're not understanding the impact of earlier experiences on your current dysregulation. We're also seeing a lot of misdiagnoses of bipolar disorder, in my opinion. So I have tested hundreds of kids in my life, literally hundreds. I have diagnosed hundreds of kids with trauma. I've diagnosed 3 with bipolar disorder, 3. So the stark contrast between that, and I'm not saying I'm always right, I'm sure I'm not, but just the statistics alone with that comparison of 3 compared to hundreds, I think is important to understand. So whenever you see bipolar diagnoses, please question it. What is driving that mood dysregulation? What are driving those risky behaviors? If you see me start diagnosing bipolar disorder more, please check on me. Something's going on. Okay. So trauma feels chaotic. There's a tendency to feel comfort in chaos because that's what you've experienced. So sometimes I hear parents say, I don't know what's going on. Things are safe now, or they're good. I don't know why they're still struggling. It's because they've had this experience that's been so impactful, and it's almost a comfort zone. I see this a lot in kids who have been adopted out of foster care or who have experienced really significant neglect and abuse, and now are with a different family. There's this idea that now they're out of that situation, things should be better. It doesn't work that way. And sometimes we see kiddos actually somewhat create some of that chaos, and it's very confusing, but it's because that's where their brain feels comfortable. That's what they're used to. Again, they're not being bad, they're not being difficult, they're traumatized. Okay, there's also a need for control often with trauma, and I also see a lot of misdiagnosis of OCD. It's important, yes, sometimes OCD is a thing, right? It exists, just like ADHD. But if we see a diagnosis of OCD and there's trauma, that's a questionable thing. Like, is it just a need to maintain control or regain control? Okay, so I'm gonna just touch on this quickly because it's a topic that kind of gets irritating for me. So diagnoses, our diagnoses are terrible for trauma, especially for kids. So our PTSD criteria is poor. I've already talked about that. We also have this other or unspecified trauma and stressor-related disorder category. I use that the most because then I add a qualifier. I might say attachment trauma. I might say developmental trauma. Reactive attachment disorder, I don't love that diagnosis either because it puts the onus on the child. There's something wrong with you that you're not attaching. And I think we have to understand most of the time that's driven by trauma, so I'm likely to go to PTSD rather than RAD. Similar with disinhibited social engagement disorder. Acute stress disorder is up there as well. One of the things that I wish got into our DSM-5 that didn't was developmental trauma disorder. I'm really hoping for that 6th edition we can get that in there because that really describes most of what the kids I see, at least, have experienced. Something in their development has been traumatizing, and therefore they have symptoms based on that. Okay. So from an attachment lens, from a developmental lens, optimal relational and brain development occurs when we have positive experiences of nurturing and safety. And that leads to positive core beliefs, leads to this idea that I can kind of conquer the world, I can be the kind of master of my own future, like all of these things. So that's great. How often that happens is unfortunately fairly uncommon. When we have attachment trauma or trauma in our development, it leads to negative core beliefs. And this can be related to abuse and neglect. I highlighted neglect because neglect tends to be the most impactful early childhood experience that leads to later trauma symptoms, and it's hardest to intervene with. So that's why I highlighted that. It can also include loss of or separations from a parent. It can include medical experiences or early pain, even early pain that you don't necessarily have cognitive memories about. It can also be that a sense that a parent failed to protect. So one of the kiddos I worked with who was a sexual abuse survivor, we had to work through her feeling that her parents weren't there for her and didn't protect her from that sexual abuse because it occurred on multiple occasions in her backyard. So there was a lot of anger and resentment toward her parents, so we had to work through that. Also a perception of rejection. And this one made me panic when I became a parent myself. I was like, I'm not even like gonna reject her, like, but she's gonna perceive it. Like it was very anxiety provoking. But we can really work through, I kind of go by the 80-20 rule. So 80% of the time, let's work on being really validating, nurturing, and then that 20% of the time when you fail, it's okay. I also, the other thing as an EMDR therapist, I thought about doing for my kids was like a notebook of all their little T's and like handing it to them as a graduation gift. Here, go work on this in therapy. Good luck with that. I'm sorry. I haven't done that, but I've thought about it. I have 3 kids, and I'm like, oh, that's a little T that I just did. Oh my gosh. Okay. Okay, so let's talk about intergenerational transmission. And sorry, yes, I'm keeping an eye on my time. Okay, so I'm not going to describe everything on this slide because I'm not a geneticist, but again, what we know now is what good therapists have known forever is a lot of different things impact how genes are expressed. So it's not necessarily that our genetics change with this type of developmental trauma, but our genes' expression changes. So experiences might either lead to genes being activated or genes being repressed. And this can work in both the positive and negative direction. So I've focused a lot on the negative today, but it doesn't mean that positive healing experiences can't make our epigenetics and our DNA express positive things. So that's just a thing to keep in mind. We can do both. All right. So I think it's important to really, from this trauma-informed lens, think about how does this behavior make sense? And again, I've said this a couple times, but if you don't yet have a reason, it's just because you haven't found it yet. It doesn't mean there's not a reason. Talk through a case, talk through a family member's behavior, just talk out loud with a friend, a colleague, really try to figure out where is this coming from, why is this happening? Also think in a timeline. So what was their temperament like as an infant? Then what happened? What changed it? Or what made it more difficult or less difficult? So I also, when I do clinical interviews, I talk a lot about very beginning attachment. So I talk about breastfeeding, sleeping. What was it like when your kiddo came home? How was that experience for you? We want to understand, even kind of going back into the generations, how can we build this attachment relationship to be just as safe and nurturing as possible? So ask these early questions and try to understand from the beginning what things were like for this kid. And then our job as professionals is to describe how those behaviors make sense given a kiddo's temperament, personality, the trauma, and any systems that impacted their symptom development. So school, family members, extended family, friends, church groups, spirituality. How do these systems really impact where they are now? And if we can understand all of those bits and pieces, we have a much better chance of intervening in a positive way. All right, so I'm gonna wrap up with some recommendations related to both individual therapy and then us as a society, what we can do. So treatment recommendations related to trauma, our psychoeducation about it, help your families understand what's going on. I do this all the time when I do testing and I diagnose kiddos with trauma. I give families the context of that. I talk about, okay, these behaviors make sense given what they experienced. These behaviors make sense given. I always try to push, these behaviors make sense, because they do, they absolutely do. It does not mean they're healthy or effective, and we'll work on that later. But the first step is understanding why they're there and how they make sense. All right, we also want to increase the window of tolerance, which is an EMDR phrase, but just the window of tolerance is our ability to kind of be present. It's our time where we can we can learn, we can engage in relationships in a positive way, we can be mindful. So we need to focus on distress tolerance skills to increase that window of tolerance. We can also do things like encourage our patients to write a letter to a younger version of themselves. Be kind to your younger self. Understand that they were struggling. Lots of mindfulness techniques, grounding techniques, connection to powerful others, and there's a couple other tools on here that I don't have time to talk about. What can we do as a society? So generally, enhancing protective factors is extremely important. Working on helping parents nurture themselves, nurturing each other, really being there for each other, encouraging stable family relationships, just good household rules are important. Parental employment is a protective factor. So all of our social determinants of health, if we can focus on as a society, we can certainly prevent some of these more difficult aspects of trauma. We can also provide caring adults outside the family who can serve as role models or safe folks. Okay, I don't know, this is going on around on LinkedIn a lot, but I just think it's a good illustration. Like, we just need to be kind to each other because we don't understand a lot of what's going on. And how, in my world, all of that blue is trauma. That's what we need to understand. Okay, last slide. Other things that we really need to focus on, I believe, as a society is prevention. Be kind, be compassionate to each other. Approach things with curiosity and not judgment. I think we can build a society at the individual level that will collectively benefit us. We also need to build a village. So have supports in your life. Really focus on helping our patients build that village as well. Integrated care is a huge opportunity for us, so integrating mental health care and screening in primary care clinics, pediatricians' clinics, that's most of the time where families first encounter health care. So if we can integrate into those places, it's great. There's something called the Healthy Steps program, which is an intervention for 0 to 3, supporting parents to become more nurturing, help their kids stay safe. There's lots of things out there that we can do. Parental depression screening and intervention is also useful. Also the social determinants of health. Home visits are good, so there's lots of things we can do to really prevent trauma and intervene if it happens. And then just finally, support each other. If we can be kind to each other, I think that's going to go a long way. Even if someone has already been exposed to trauma, they need that kindness, they need that connection. And I think we can take that upon ourselves just to move to the world in a kind way. All right, that's it. Thank you.
Thank you, Dr. Deming. We also have a gift of gratitude, and we'll give that to you. And thank you so much for making time to be with us and being here. It's fantastic. I know we're all better for having been here and been with you. We have a break, and we'll be back at 10 o'clock. There's food out in the hallway there, and feel free to go there and get what you need and be back at 10. So thank you, everybody. Welcome back, everybody. Hopefully you got a little break and attended to what you needed to attend to. We, just so you're oriented, we've got this next speaker, and then in our next break, the bookstore will start selling books. Kristen Neff's book. She'll also be here doing a book signing, so be aware of that. That will go right up until about 15-20 minutes before the end of lunch, just so you have some idea there, and you're welcome to help yourselves there. So we are really, really excited and grateful to have Colleen Cowperthwaite with us, and yes. Thank you. It's the kind of excitement we like at this conference. That's why it's the Family Matters Conference. She is a licensed clinical psychologist, assistant professor, and associate director of the dialectical behavioral program or therapy program in the Department of Psychiatry and Behavioral Sciences at Duke University Medical Center. Clinically, she provides individual and family-based cognitive behavioral interventions for adolescents, young adults, and adults with a variety of psychiatric and medical diagnoses, including personality pathology, chronic suicidality, non-suicidal self-injury, mood and anxiety disorders, PTSD, and trauma-related disorders. In her faculty role, she provides training, supervision, and education for graduate students, clinical psychology interns, and psychiatry residents. Dr. Cowperthwaite has been recognized for her clinical teaching with an outstanding didactic teaching award from Duke Psychiatry Residency Program, and her research focuses on adaptation and implementation of contemporary family-based and cognitive behavioral and dialectical behavioral therapies. So we're in for a treat. Please give Dr. Cowperthwaite a big round of applause and welcome.
I have known Brad for 5 years, and that's the first time he said my last name right. All right, so yes, I'm going to be speaking about understanding and supporting emerging adults with a bit of a flair for this sort of new post-COVID era. Relevant financial disclosures: I serve as a consultant and receive compensation for that from the Sunrise Residential Treatment Center for Teens. Those ones. And I am going to start actually with gratitude. The Duke team that's going to be up here in a little bit consists of Zach Rosenthal, Noga Zerubbabel, and Kristen Wyatt. Zach is my mentor and the director of the DBT program where I am situated at Duke. Noga was one of my postdoc mentors and supervisors who taught me about trauma. And Kristen co-developed an emerging adult DBT program with me. So I literally couldn't do anything else on this talk without those three humans. And then huge gratitude to the Sunrise folks. We have been here 8 times in 5 years to hang out with y'all. You are the reason that this is such a special geographic place in our lives. And then I also want to start with just sort of orienting y'all to what I bring to the table. So my lens is the way that I am situated. Cisgender, Caucasian, able-bodied human. I strongly identify as a millennial, which may influence how I interact with some of my Gen Z, emerging adult, even Gen Alpha patients. I am married, and I am a parent. And so I'm sure all of the parenting advice I used to give, I will bite my tongue pretty soon. Again, I am primarily a clinician, primarily do therapy, and then a big part of my role at Duke is as a clinician educator. And then I am an associate director of an outpatient DBT program, and as part of that role in the outpatient DBT program, I created and did some research on a special adaptation of DBT for emerging adults and their families. So again, these are the lenses through which everything else in the talk, this is how I see stuff. Objectives for today: to explain patterns that are characteristic of emerging adults and their families, to, again, as a clinician, describe some sort of clinical considerations for developmentally tailoring family-inclusive care for emerging adults, and then to provide, hopefully, some like nuggets, some recommendations for students who may be going into this field, for providers, and for parents and caregivers. Again, because I am primarily a clinician, I am grounding everything we talk about with a couple of case examples. These are de-identified, these are sort of amalgams of multiple patients of mine, and these could be any number of a dozen of patients who I've seen over the years. So Maria, an 18-year-old cisgender Caucasian woman, came to me with social and generalized anxiety, depression, ADHD, a sort of, thanks to Dr. Deming's talk, right, like a long history of bullying through elementary and middle school, super excited to start high school, to like get a fresh start and make new friends who aren't jerks to her. And then COVID-19 hit the spring of her freshman year. Everything transitioned to online, and she had a really hard time maintaining that connection to her brand new friends from freshman year of high school. When school resumed, she never quite got back into it, and then had her heart broken by a boy and engaged in some school refusal. We were talking at Sunrise yesterday about how they sort of anecdotally have observed a lot of school refusal in like the anxious, neurodivergent kind of kids, this kid to a T. So now she finished out high school in an online academy. She's 18 years old, living at home with her middle school age sisters, has a really hard time with like self-regulation and structure. By her report, no friends, and really like desperate and lonely and pulling for relationships wherever she can find them. This led to her attempting to make friends online, stumbling into like really ineffective, unboundaried relationships with men on the internet, some like awful catfishing stuff, and her mom freaked out. Mom blocked everything, blocked all of the internet, took away her car, and so Maria got super hopeless, depressed, relapsed on cutting behavior that had been present in high school, says, man, I wish that I'd never dropped out of high school, and last week said, can you tell my mom I have a boyfriend now? The other example is a grown-up. So Hallie, a long-term patient of mine, middle-aged Caucasian heterosexual cisgender woman, has 3 young adult children, initially presented for her own PTSD for multiple experiences of sexual violence, sort of as an emerging adult herself. Came to session last week and said, I need a break from trauma processing. I need to talk about my kid. I need parenting advice. I know that you're the parenting person. Her youngest son got in some trouble in his frat house on his college campus. And Hallie, in sort of her own script, was like, I made bad decisions when I was in college. I ended up getting really hurt as a result of those decisions. I don't want this to happen to my kids. I need to pull him. And had urges to pull him from college, make him move back home because he doesn't know how to live in community with people. He doesn't know how to share things. He doesn't know how to be respectful of people. And so, again, she wants some advice from me on whether or not she should pull him from college and move him home. So again, this is how I think as a clinician, as an educator. So everything we're going to be talking about today, I am thinking directly about how I might be applying it to these kinds of patients, again, who I have in dozens. So to sort of set the frame, I didn't come up with the term emerging adults. This is a Jeff Arnett thing. It is conceptualized as a distinct developmental stage, sort of between adolescence and adulthood, mostly thought of as 18 to 25, but some folks scooch it all the way up to 29. It was not empirically derived, it was derived from like observations of shifts in timing of traditional adult milestones. So over time from the 70s, timing of having your first kid has gotten later. Timing of getting married has gotten later. Timing of financial independence has gotten later. And then also, again, characterized by a lot of flux, a lot of change, a lot of frequent transitions, ambiguity, exploration. Arnett had these sort of 5 features of emerging adults. According to him, emerging adulthood is characterized by identity exploration, which I think for a lot of us in the room has a lot of face validity. Like, yeah, that is the job of adolescence and young adulthood, is to figure out who you are and what you care about and what you're about and what your values are. He also identified like instability. This is the rule, not the exception, that emerging adults experience a lot of change, frequently change jobs, frequently in and out of friendships and romantic relationships, frequently changing living situations, leading to this sort of like not having a stable, your feet on the floor, a sense of instability. Identified sort of a self-focus. So emerging adults, he identified he hypothesized that because they have sort of fewer social roles or obligations compared to other people in other life stages, they can sort of be more free to focus on themselves, which some of us might see as like sort of narcissism, and for these young folks, like that's all they're working on is them. Again, this sort of like not quite adolescent, not quite adult leads to this sort of like felt sense of being like in between. So they haven't fully reached adulthood. They, again, not quite having a firm sense of the ground under them. And then the last one I sort of love. Arnett identified a feature of emerging adults, a characteristic of like optimism and like a sense of like the path is open and there's all of these possibilities, despite facing challenging economic and social conditions. So Arnett was writing about this during sort of like the Great Recession. And even then, just this sort of like sense of like, things will work out. I'm gonna be great. The future is bright. The future is full of possibilities. Again, characteristics that sort of go along with some of these features. Emerging adults, again, since the 70s, we have seen this shift. It does not want to stay connected. Of increased college attendance and completion. Emerging adults often enroll in college directly out of high school, spend more time in college and pursuing like tertiary education. Leaving and returning home. So emerging adults, once they fly the coop, they come back. So they are frequently leaving home, but may periodically move back in. Frequent job changes, multiple job changes, periods of unemployment and underemployment. The median number of job changes for 20 to 29-year-olds is 8. And so this can lead to sort of this feeling of being unmoored, right? If you are in and out of where you are moving, you are in where you are living, you are in and out of building community at school or at various jobs that you might not stay at for very long, it can be hard to sort of develop your community, develop your sense of self. And then again, emerging adults, since the 70s has, there's a lot more dating. There's a lot more in and out of romantic and social relationships. There are stretches of cohabitation with a romantic partner, and then periods of having no romantic partner at all. And again, these are the features. These are not the exceptions. This is sort of the norm for this developmental phase. So Kristen and I wrote a chapter in this book, and the very first chapter in this book was about how failure to launch used to be this pejorative thing. There were clinics that popped up all over the country as like failure to launch clinics. For if you didn't, your 20-year-old wasn't out of the house yet, we need to figure out how to get them out of the house. This is no longer a pejorative. This is now like descriptive. this is now a typical pathway to adulthood, is to do the stuff that we used to call like sort of delayed adolescence. So just some numbers to back this up. If fewer than 20% of 18 to 24-year-olds are financially independent, able to fully support themselves. Nearly 60% of young people live with their parents. This is a huge shift in like half a generation. So this is like in the past 15 years kind of shift to more people living with parents or caregivers for longer. The median age of first marriage now is, and first birth for people who have kids is 30. The typical age, again, seems to be moving. And there are probably some like social and demographic reasons for that. Along with that, that's sort of the typical stuff. There is also sort of layered on top of that a dramatic change in mental health prevalence. Prevalence of sort of diagnosable mental health disorders. So part of the thinking is that, like, if we're thinking of Gen Zers who are the current emerging adults, they are much more like psychologically inclined. They have much better language to describe their emotions. They might just be much more like decreased stigma about seeking mental health. So some of this seems to be explained with like, oh, the Gen Zers are anxious because they have words for it now. The other part of it is that like, no, there's actually like behaviors that are mapping onto this, right? So they don't just have better language to describe anxiety and depression. They're super suicidal, right? Like they're engaging in self-harm behaviors. 25% of teen girls have made a suicide plan. 25% of LGBTQ students have attempted suicide in the past year. So this is not just we have better language or we have better ability to sort of pick up on stuff. There are actual changes in prevalence of pretty scary, risky behaviors. Other sort of challenges with this phase that might not be Gen Z specific, the age of onset, we have known this forever, the age of onset for many mental health disorders is late adolescence. So 3 and 4 lifetime mental health disorders will have an initial onset prior to age 25. There's a high prevalence of mental health disorders in 18 to 29-year-olds. So the 12-month prevalence of any kind of disorder is 40%, particularly mood and anxiety disorders and substance misuse. And then there is, for this cohort, a low engagement with mental health services and high treatment dropout. So while these folks have more diagnosable conditions that have gotten worse and more prevalent in the past 15, 20 years, they're also engaging in treatment less. And once they do engage in treatment, having a harder time sticking with it. Some of the stuff that might be contributing to like higher anxiety, higher mood stuff, this particular graph came from Jonathan Haidt, who directly correlates it to when we got cell phones. So like when we got smartphones was like 2012, and like that's where you see, as Zach calls it, the hockey stick curve. And so Haidt says like it's the decrease in play-based learning and the increase in phone-based learning. It's the decrease in like play-based social relationships, the increase in like social media, that might be potentially a contributor. And for other folks, it might not be that. It could be some of the contextual stuff, right? Like financial worries or achievement pressure or this like loneliness, this pervasive loneliness or lack of meaning or purpose. This sense that things are falling apart. So whether it's gun violence or climate change or like incompetent or corrupt political leaders, like they're in this cohort seems to be this sort of pervasive sense, which is so funny when you think about the possibilities and optimism, right? This pervasive sense that like things are falling apart. And if you think things are falling apart, if you think the sky is falling, that's very scary. So of course you'd be anxious. So again, hoping to bring sort of a lens of what the past 4 years has been like, COVID-19, it turns out, didn't make any of this better. for a lot of young folks, folks around the world, not just young folks, the COVID-19 pandemic caused just a disruption in daily life, a disruption of routines. And that sort of disruption led to, for a lot of folks, a negative impact on well-being and mental health. Emerging adults, again, a lot of the Arnett stuff came out around the Great Recession, and now we have sort of another version of that after COVID, that emerging adults have faced a significant decline in job opportunities, dampening of wages, increased financial instability. There's not a county in the entire country where you could get a one-bedroom apartment on minimum wage. Lower life satisfaction, so especially for the cohort that was sort of just beginning to launch, they're super disappointed when they had to return to their parents' or caregivers' homes. They're super disappointed that they had to defer life plans like going to graduate school or getting married. These, again, sort of like disruptions, disappointments, deferred plans has led to overall decreased, lower levels of life satisfaction. And then, again, they were already an anxious bunch, and since COVID, we have seen emerging adults in particular have higher rates of depression and anxiety compared to other age groups. So they got even more anxious than the rest of us did as a result of COVID. Emerging adults were not the only ones affected by this. Again, I am a parent of a 2-year-old, not a parent of a 20-year-old, but I hear it's pretty anxiety-provoking to be a parent of an anxious 20-year-old. So parents of teens have rates of anxiety and depression similar to the rates of anxiety and depression that teens have. Parents of emerging adults who had to sort of like, they started launching and then had to move back home, parents of those young adults have lower quality of life compared to their friends, their buddies who don't have sort of cohabiting young people with them. This middle one is sort of can be cut either way. Emerging adults, this particular cohort, is more likely to seek emotional support from their parents than their parents were before them. Which again, in some cases is sort of lovely. And in other cases, parents are experiencing as either burdensome or like, I don't know what to do, I don't know how to help. This is a completely different world. So seeking out parents for advice and social support that the parents don't necessarily feel like equipped to be able to offer. And then finally, financial strain. Because of this, like it takes longer to launch financially. For folks, parents of relatively lower income brackets, this is actually really burdensome. It's delaying things like saving for retirement or taking care of younger children. So for like middle and higher income parents, the kids are relying on them more, but it's not as burdensome. But for a subset of the population, it's really taxing on parents' lives. So again, sort of a cool thing that emerging adults reported becoming closer to their parents during the pandemic, and parents are sort of anxious and depressed and freaked out about this. So one of the ways that I conceptualize and understand emerging adults and caregivers is directly pulled from adolescent DBT. So I'm one of those DBT people that Dr. Deming was talking about. Dialectical behavior therapy. So the folks who adapted dialectical behavior therapy for adolescents and families came up with this sort of understanding of how parents and young people interact, and how the way that parents and young people interact might lead to sort of like primary problems. So we sometimes talk about these as sort of opposite ends of poles. So one of the patterns that we talk about in adolescent and emerging adult DBT is making light of problem behaviors versus making too much of typical behavior, right? That parents or caregivers might have a really hard time figuring out what is like normal teenage stuff or emerging adult stuff versus what is something that's really like pathology or like cause for concern. And the teens or the emerging adults also don't know where sort of that red line is between what's normal and what's cause for concern. You can see how this would be really challenging since the norms are changing so quickly. Another sort of dialectical dilemma that we call them is forcing independence versus fostering dependence, right? So this is like the roots and wings kind of dialectic, right? When are you, by trying to take good care of your kid, or I think the New York Times called it like snowplow parenting, where you're like clearing the path, trying to make life easier, when might that be like sort of blocking the emerging adult from like gaining the skills that they need to be able to launch successfully, versus when are you expecting them to have capabilities that they don't have, they've never had an opportunity to learn or practice, and pushing them out the nest anyway. And again, this can happen for young people too, that there are ways in which they feel dependent and ways in which they feel independent, days that they feel independent, days that they feel more dependent. And so we see this sort of like swing or flux. And then finally, too loose and too strict. This is particularly hard for, again, emerging adults who are 20, 22, 26 years old living at home and expected by their parents to follow the same curfew that their high school age siblings follow, right? Like when is that like holding on too tight, too strict, like not allowing sort of natural developmentally appropriate exploration? Versus when do you not have expectations, right? When are you not actually like pushing your young adult to do things that they are capable of doing? So this sort of leads us into treatment. So emerging adults are hard to treat. They can be hard to treat because of this sort of like falsely dichotomized, at least in medical centers like where I'm situated, the kid side and the adult side. So like a 17-year and 11-month-old person can be in the kid clinics, but 18 years and 1 day has to be in the adult clinics. And it turns out there is data to say like putting an 18-year-old, the kind of therapy that I do, putting an 18-year-old in a DBT skills group with 65-year-olds, they don't do super well. Like they do better when they are around people their same age who have some of their same reference points and are practicing the same skills at the same time. And that's hard to do in our existing medical systems. Treating emerging adults as adolescents, on the other side, underestimates their capacities, underestimates their capabilities, and frankly, some emerging adults find it insulting. When they are sitting in a waiting room with toys in the waiting room, the skills manual that they get, at least again, in the kind of treatment we do, the font is Comic Sans. Like it's a little bit infantilizing for emerging adults. There are no specialized assessment or treatment methods for emerging adults with mental health needs. Again, this concept of emerging adulthood as a new developmental phase is like 20 years old. It's actually in like the span of developmental theories, not that old, and we haven't yet developed specialized assessments or even like what is normal and what is not. Emerging adult autonomy, I hear this from like heartbroken parents who call me all of the time. They can't mandate treatment for an 18-year-old, right? So part of the difficulty getting into and staying into treatment is that emerging adults can refuse. They cannot do it. They can be flexing some of that independence by turning down stuff that the grown-ups in their life think would help them out. And then finally, the transition to independence. With all of these moves, with all of these job changes, with all of these changing roles, it can be really hard to get access to treatment in a new city where you don't know anyone and you don't have health insurance. So there are just like fundamental, like functional barriers to even getting these young people in the door. So if we were to get them in the door, what might we do? So treatment approaches for emerging adults, there's not a ton of them out there that are age specific. There's a lot of, again, really good evidence-based treatments for kids and adolescents. We obviously have very, very long history of really good treatments for adults, but this specialized developmental phase, we don't have a ton. What does seem to exist seems to cluster around like cognitive behavioral or transdiagnostic approaches. We talk a lot about like the interconnectivity and processes that affect each other, and this is very true for this cohort. Again, like part of why they're anxious is because they are experiencing financial instability. Part of why they're experiencing financial instability is because they don't have the practice skill sets to be able to go out and get what they want. Part of the reason they don't have that is because they haven't had an opportunity to practice, and also because they're anxious. So like all of these things are intertwined, and so the innovative treatment approaches tend to be a little bit less, kind of like Dr. Deming was saying, a little bit less like disorder focused, and a little bit more reducing symptoms while at the same time teaching like life skills through like cognitive behavioral interventions. Most of the like good stuff out there for emerging adults includes caregivers, includes families. If caregivers are living with their, or if emerging adults are living with their parents and caregivers, then we might as well intervene on the environment at the same time. Again, the environment's super anxious and depressed anyway. The environment doesn't know how to help anyway. So it's sort of this, all of the like good stuff out there for emerging adults takes that context into account and treats that system too. And then finally, like I was saying, that we have data to say that sticking an 18-year-old in a same clinic with 45, 50, 60-year-olds and expecting that they have the same needs doesn't work. And so the good stuff out there for emerging adults tends to be both age matched in terms of like if there are group interventions, and also provide opportunities for safely developing and practicing social skills, safely developing and practicing like emotion regulation skills, safely developing functional skills. Again, all of these things are interrelated processes and could be really awesome opportunities for growth and resilience and insight. This cohort is awesome and emotionally aware and talks super openly about emotions and mental health struggles. And so the really good innovative treatment approaches take that into account. Some samples of programs, Kristen and mine. So we adapted adolescent dialectical behavior therapy to 18 to 25-year-olds. So to the problem of the manuals, we took some of the stuff from the kid book, which is literally Comic Sans, and some of the stuff from the grown-up book, right? Some of the language about emotions in the kid book was too easy, so we used some of the language about emotions in the adult book. We had young adults and their parents or caregivers in the same room learning the same skills at the same time. Because again, it is anxiety provoking to be a parent of a struggling young person. They need distress tolerance skills too. They need emotion regulation skills too. So we just taught them. We provided skills coaching to both the emerging adults and to the parents or caregivers. So we adapted this treatment specifically and age matched it specifically for 18 to 25-year-olds. Other stuff out there, Kristen and I have worked a little bit with Anne-Marie Albano up in New York, and her version of this is called the LEAP program, Launching Emerging Adults program. It is more disorder focused. It is specifically focused on targeting anxiety, but also half of the content is about like developmental transitions. It is 22 sessions. It's some individual stuff with just the young person, some group stuff with just the caregivers, some multifamily groups, some family sessions with a heavy dose of like psychoeducation for families, again, about what's normal versus what's cause for concern, with cognitive behavioral skills, like cognitive restructuring and problem solving, helping parents to sort of like transfer some of the responsibility. There's cool stuff in this content about like, can your young person use an alarm clock to wake up on their own at a reasonable hour? Or like, can your young person like stay within a budget? Can your young person call and make doctor's appointments on their own? And so again, sort of in little kid stuff, this is called transfer of control. In emerging adult, it's called transfer of responsibilities. But actually built into this content for this treatment program is like decreasing dependency on caregivers, helping everybody like accept all of the emotions that go along with role transitions, and then help the young people like attain and stably maintain behaviors necessary for independent functioning. And then the final example came from autism world, right? So the PEERS program at UCLA was originally developed as a 16-week group social skills training for young people with autism, and it has sort of blown up since. And so it's all over the world. It's kiddos all the way up to emerging adults, and it's now transdiagnostic. So it's any kind of processes that might interfere with like, you know, social processing, and it's young adults, caregivers in a group with skills training and role play for the stuff like developing and maintaining friendships, safe electronic communication, handling disagreements, having hard conversations. And again, like built in is these safe opportunities to practice the skills. So from that, some sort of research-based recommendations. If you're gonna be doing work with emerging adults and their families, it should be pretty skill heavy. Provide opportunities for problem solving, for decision making, for boosting up and reinforcing self-regulation skills. Provide explicit opportunity for like figuring stuff out. Foster identity exploration. Facilitate, again, safe experiences to allow emerging adults to explore their interests, do values clarification, to look around at different kinds of career paths, to set goals, right? They feel sort of rudderless, so give them opportunities and build in experiences to cultivate a sense of purpose and direction. Strengthen the family connections. Again, the emerging adults are situated in their home environment anyway. They're going to their parents and caregivers for advice and emotional support. And so let's just foster that connection through open communication, through teaching collaborative problem solving, through practicing like boundary setting, both on the emerging adult end and the parent or caregiver end. And then finally, enhance mental health support. We gotta find ways to get these young people into clinics and keep them in clinics. Probably gonna do that with actual developmentally adapted, culturally responsive services, coping strategies, actual like concrete stuff. This is really fun, it keeps doing this. So if those are the recommendations, then let's bring it back to how we started, and that's with our people. So with my little buddy Maria, the way that we went was full model outpatient DBT. And what full model means, again, is a skills training group, coaching calls between session access to me, individual therapy per week. Get her the emotion regulation and interpersonal effectiveness skills that in her own estimation, she sort of missed out on a critical opportunity in high school to actually gain. We have monthly family sessions, and we use those monthly family sessions to focus on interpersonal skills practice between kiddo and her mom and problem solving. Again, collaborative problem solving, so that it's not mom doing it for her, and it's not kiddo who doesn't know how to do it, just making stuff up. I recommended individual therapy for mom. This is a prime example, this family, of mom freaked out because mom was anxious about what would happen to her kid if she got in a really unsafe relationship with a 55-year-old man in Texas on the internet, right? So we needed to get mom to do some values clarification for herself and to manage her own anxiety so that she can parent from values and not parent from fear. And then I'm so glad that I found the PEERS program, right? Because we had to consider some sort of ancillary services. So right now, our groups, the way they are at Duke, she is in there with like 45, 50-year-olds, and her problems that she's bringing to group as home practice examples are really different from their problems. And so we needed to get creative to get her a young adult social skills group to help develop some of her social communication abilities. Again, she feels like she missed a critical window for being able to develop those in high school. And she did an awesome job. She found an interpersonal process group at her college. And I was like, fine, do that. That sounds awesome. Again, around other people who are coming in with sort of the same frame and need safe places to practice new and developing skills. For Hallie, for my grown-up, we had to do a whole bunch of psychoeducation on like behavior change principles. Again, this like what is normal versus what is cause for concern. Like borrowing stuff from a frat brother's room, like that's pretty normal. Like that's not pulling from school worthy. Again, a whole bunch of values clarification as a parent of an emerging adult. We did a lot of role plays for setting and observing limits. So like doing something that is developmentally normal for an emerging adult does not mean that it's without consequences. So helping her to figure out like what kinds of consequences, interpersonal or financial or otherwise, would make sense, and then actually practice holding to it once she sets those. Creating opportunities. So we didn't have family sessions, that was the frame, but we did a lot of trying to build into her schedule and her family opportunities for curious, open, non-judgmental communication with her son, asking him what he's about, asking him what he cares about, asking him what his values are, and then using all of that to engage in collaborative problem solving to aid him in values-oriented decision-making. And she was the one who told me this, and I'm keeping it forever. She said, in our house, we say, what would Jesus do, and what would Colleen say? And so even when I'm not treating a family, I'm probably treating a family. It is impossible to see this woman, who I was seeing for childhood trauma, right? It's impossible to see her like outside of the system in which she's oriented. And that when she changes her behavior, it's gonna affect everybody else around her too. So, some recommendations for providers. Beef up your skills on transdiagnostic therapy. Focus on improving overall functioning, building core skills, rather than targeting a specific disorder. Again, a skills-focused approach, practical, real-world life skills kind of stuff. Be super flexible. Again, knowing that the targets change all of the time because the context changes all of the time, because these folks are in and out of relationships and jobs all of the time. You sort of have to dance with it and do a lot of improv. Don't be scared to incorporate family and caregivers, even if you are not oriented in a system where family therapy with a 19-year-old is easy to do. Figure out a way to even do like family-assisted individual therapy. Again, to help support your primary patient overall well-being, practice collaborative problem solving. And then if you can, seek out age-matched grouped interventions. If it's not within your system, get to Googling like I did to find social skills groups around peer support that is appropriate for your patient or client's developmental level. And again, among folks who are also have the frame of practice. And then broad social support. These young people are lonely. They don't have this like so-called third spaces that the rest of us grew up with. They don't like go sit at a coffee shop. They're pretty isolated. So we gotta get super creative to find ways to expand the client's social network and access to community resources. Those of y'all in the room who are students, please take a developmental psych course. Even if you think you're not a kid person, like just knowing, again, what is normal versus what is cause for concern, or like how are things shifting over time, is gonna blow your mind, and like Dr. Deming was talking about, help you understand a lot of the why stuff shows up when it does. Again, even if you think you're not a family person, pursue training in family therapy. Because the family context is always present, even when they're not in the room. The internship that Kristen and I did, because we were on the adult side, we weren't allowed to do the family therapy training. And so we sort of had to come to that training on our own. So those of y'all who are students, do it now. And then explore systems theories. Everything is complex. Everything is interrelated, whether it's these sort of bidirectional relationships between parent or caregivers or the bigger, larger systems that, again, contributed to a lot of how these folks are feeling about the world. It can be helpful to understand as a student, as somebody going into this field, to think about how your identified patient situates themselves in that larger overall system. And then finally, for folks who might be parents or caregivers in the room, recalibrate for yourself what you think is normal. Again, like failure to launch is normal now. And so adjust your expectations. Their growth and development may not fit traditional timelines and definitely doesn't fit the way that you came up. Still have to have a heavy emphasis on positive reinforcement. Reinforce effective self-regulation to encourage like growth and learning. And then, like my buddy Hallie, allow natural consequences. Again, sort of the like snowplow parenting is like make things relatively easier, block bad things from happening. We are now seeing that this might be inhibiting our young people learning, like experientially learning how to do stuff. So permit, allow age-appropriate and natural consequences to occur. So again, Hallie needs to let her young son like go to the honor council and feel what it's like if his frat brothers don't like that he goes in their room uninvited. That is stuff that's going to help him socially going forward. Parents need to practice letting go of control. Emerging adults need to practice accepting responsibility, and doing that will help the emerging adults build sort of self-efficacy and confidence. So in conclusion, emerging adulthood, again, 18 to 25-year-olds, it is sort of hypothesized to be a unique developmental stage characterized by identity exploration, instability, self-focused, feeling in between, and a sense of possibility against all odds. Emerging adulthood is associated with increased risk for mental health issues, including anxiety, depression, and substance use disorders. Parents and adult children are living together more and for longer. Parents and young adults are more reliant on their parents for financial and emotional support. And this has impacts both on the young person's sense of self and sense of self-confidence, and also on the parent's experience of anxiety, depression, and distress. This stuff is changing and really super fast. So again, COVID negatively impacted life satisfaction, negatively impacted mental health for this cohort, the specific cohort of Gen Zers right now. And then try to create specialized interventions, CBT, DBT, process-focused transdiagnostic therapies, and don't be scared to look at ancillary treatments for emerging adults and their families. Thank you very much.
And thank you to Dr. Cowperthwaite. We're grateful for her and appreciate it. I know we're better off for having been here. We've got a 10-minute break. Come back at 11, and we'll have the rest of the Duke team come up, and you'll get to speak with them. Just so you're oriented, we do have Dr. Kristen Neff is here doing book signings. If you want to purchase a book through the bookstore or have your own books, you're welcome to come and do that. And that'll go till about 11:45 for those book signings. So just be aware of that. So take a break, get some food, and we'll come back. Thank you, everybody. Welcome back, everybody. Happy to have you and good to be with you. Hopefully you're able to get your book signing if you needed that and get out there. Those books are for sale. We'll have the Duke team come on up. We're grateful for them and grateful they'll take this time. This is really an opportunity. They're going to expand a bit on the topic we just heard about, but really an opportunity for question and answer. If you've got some questions, please send them their way. So just so you're oriented, lunch will be right after this from 11:30 to 12. It's intentionally a really quick, short lunch. So the whole idea is if you have a ticket, take it out there, give it to them. They'll give you your food, and then just come right back in because we're starting right at 12 with Dr. Neff. So really eat in here is the intention. So we had a tight window, and thanks for making it work. Those that didn't pre-register, you didn't get a ticket. That's partly intentional because we want to feed those that did first. And then those that didn't pre-register, we should have enough, but I wanted to do my best to make that happen. So we'll let you know once we open that lineup, and you can go get food, those that didn't have a ticket. If you're a speaker, you do not have a ticket, but you're guaranteed lunch. That's the least we could do, right, for being here and talking to us. So thank you for doing that. And without further ado, I'm going to let each of them introduce themselves because we didn't give them very long. But I wanted you to be with this wonderful team. The cool thing about this group, not only are they amazing professionals, but they're just really good people. And it's been an awesome relationship with them. Anytime they come to Utah, they go do an adventure. So even if one of your questions is what's your favorite adventure you've done in Utah, they could talk for 30 minutes on that, which would be great. So thank you.
So maybe I should introduce myself as tour director, since I tend to organize all these things. Everybody, I'm Zach Rosenthal. I'm a clinical psychologist at Duke University Medical Center and Duke University, scientist, clinician, teacher, trainer, person, with a focus on misophonia. Actually, I would lead the Duke Center for Misophonia and lead the Duke DBT program.
I'm Colleen.
Hi, I'm Noga Zerubbabel. I'm a clinical psychologist. I work at Arise Psychological Wellness and Consulting, which is a private practice, and also have an affiliation as an assistant consulting professor at Duke University Medical Center. I love Utah, echo the love on the Sunrise crew, and I'm delighted to be with you guys.
Hi, I'm Kristen Wyatt. I'm also a licensed psychologist, and I co-founded Arise Psychological Wellness and Consulting with Noga. Before that, I was at Duke with all three of these guys and co-founded the young adult component of the DBT program with Colleen here. So I'm coming at this lens, my lens is a clinician educator lens, and work a lot with emerging adults myself as well. And I'm privileged to work with the Sunrise crew here.
Give them a round of applause. We're grateful to have them. And I'll let you guys expand on what you'd like, and then when you want to open it for questions, we've got mics here for you. So.
Well, so Brad and I were just talking briefly before. Maybe a useful thing we could do is just reflect back on Colleen's talk just now and Dr. Deming's talk this morning. Just see if there's any questions that have come to mind related to bigger picture considerations around trauma or emerging adulthood, or really anything that is on your mind. Let's start there.
Hello, thank you for being here. My question is sort of the intersection of my professional background, which is clinical social work, moving into primary prevention, but then I'm thinking as a parent of a preteen. And, fortunately, hope all the traumas are little t's. I'm sure she'll tell me later. But, as as proactive to help emerging adults be as healthy as possible, as functional as possible, and as self-actualized as possible, what are great prevention strategies for families of younger children?
Sorry, I didn't talk about specialty areas. My specialty areas are trauma and mindfulness. I'm not a younger children person, so I'll say that. But I've spent a lot of time in the dating violence and sexual victimization space. I think that both young adults who have had exposure to traumagenic environments and have the vulnerabilities associated with that histories, and young adults that have been sheltered and have not been exposed to traumagenic dynamics. You know, this possibilities aspect of what Colleen talked about is paired with vulnerabilities. It's also a very vulnerable time, and particularly relationally, because that's such a central piece then. So I do think that one of the best things that parents can do is teaching their children about positive signs in dating relationships and problematic signs in dating relationships, and how to intervene on problematic signs, and what are real red flags if you're trying to intervene on something problematic, for example, over control or something like that. If you're trying to intervene on that and the person is unresponsive, you know, escalating that to more of a red flag. So I think I would concentrate efforts in that area.
And again, I think parents and young people figuring out the what's normal versus what's cause for concern. If I think of my case example, Maria, bullying in elementary school, not normal. Like capital T trauma or lowercase t trauma, that's not normal, that's cause for concern. But getting a boy broke her heart in high school, that is pretty normal. That's not actually cause for pulling her from high school. And so like allowing some of the natural sort of bumps in the road and upsets, which might actually help the young person develop like resilience to, you know, difficult emotions, while at the same time intervening and being the grown-up when you need to be, when there is like a true cause for concern, a thing that needs a grown-up to take charge.
I'd add to that, Colleen mentioned this in her talk, and the cause for concern versus normal development is one of those poles that we talk about, but the other two, too loose, too strict, and fostering dependence and forcing independence, I think those are really constructs that are relative across the lifespan. I'd argue even into adulthood for a lot of us, particularly the too loose, too strict one. But I think those are really worth thinking about at a preteen level for things that are related to what each of my colleagues have said. I think something that we see a lot, especially amongst anxious parents, is lots of overexertion of control and under the guise of protection and wanting to protect their kids from a lot of things, blocking them from important learning experiences that give them opportunities to learn some of the things that these two just mentioned.
Also not a young child person, but a parent of two emerging adults. So thank you, Colleen. I learned some things that I need to pay attention to. One of the things that I would add that hasn't been added is that there is always a challenge with all of us, but especially when we have our youngest people, to be thinking about how do we manage aversive stimulation broadly, right? It's sort of the sense of the world has all sorts of unpleasant signals, danger signals, unpleasant cues that come our way. And of course, this is ordinary. It's totally normal. We all experience this, and we should figure out how to navigate aversive stimulation. But at the same time, we also know that we have little people with vulnerabilities, right? Vulnerabilities to aversive stimulation. So part of what I'm bringing you to is I would add something that I think a lot of us, broadly us as mental health people, overlook in understanding aversive stimulation in children is the role of sensory input. The role of sensory input as the fundamental vectors by which we experience aversive stimulation prior to us thinking about it and making sense of it with our information processing capabilities. We all experience, all of us right now, and all of us since probably intrauterine, are experiencing sensory input first as a way to then guide how we understand everything else. And for some people, for young people, for old people too, but for younger people, we first see this tendency in some people to be on a spectrum, to be a bit more likely to be experiencing aversive stimulation through sensory input. And this could be noise. Noise is a great one for this because so many people, probably all of us, have noises that are annoying to us, right? And so noise sensitivity is a thing that's pretty typically experienced. But if you bring it back to kids and how to parent, I think sometimes we don't recognize that our systems, our structures, school and workplace and all the stuff around us, there's a lot of noise aversive stimulation, and there are younger people that are really sensitive to that, and we can't sort of just write that off and invalidate these sensory sensitivities. So takeaway, looking for that, understanding that, making sense of that early on. And part of why that matters is because we know that early sensory sensitivity is a longitudinal predictor for all sorts of life problems downstream. But we as mental health people, I think we have a blind spot on that front. So I'll make a pitch for that.
Sorry, I got the microphone. He was closest to me. I'm thinking of the sensory that you're saying, and I'm wondering, are you seeing an increase in that sensory adversity? Is that what you called it? In our youth as they're growing?
Yes, and we don't quite know totally why, although I wouldn't say that there's perfect longitudinal data with hockey stick graphs yet on that.
Can I?
She presented. That's not quite there, but yes, more generally through more cross-sectional studies, looking at different time points with different populations of people at different ages, it's not entirely clear, but it also is one of these things that's getting a lot more scientific investigation now than it did historically. So it's unclear, right? It's unclear when you start looking at something, you see it more. Is that because you're looking at it more or because it's happening more?
Can I give an example of something I'm seeing?
Sure.
I don't know if anyone else is seeing this, but when children are young, they may be afraid of the vacuum or something like that. So we coach them and we teach them and we expose them and then they're fine, right? I'm seeing in even like that elementary age, more and more children at that age, they're just flushing the toilet. Like they're plugging their ears to do that, and they're putting their leg up so they can cover their ears, and I'm seeing more of that happening, and I'm wondering, what is that, just that I'm observing it more like you said, or are we seeing more of it? What is that showing us is changing in the development of our children?
I don't know that anybody has the answer. It's a great question. There could be lots of factors. But it is true that if you start looking at this issue of sensory sensitivity in kids, and you look at the people on the fringe of the spectrum of hyposensitive to hypersensitive, and you look, there's a lot of people walking around. There's people, just if we think about sound only, and just within sound, if we think about over-responsivity to particular sounds, oral and facial sounds, which are usually how we would characterize misophonia as a condition, a newly named disorder. This is roughly about 20% of the population experiences mild to moderate distress related to these oral, facial, chewing, crunching, sneezing, snorting, coughing, all of those kinds of. The tail end of that is really more like 5%. 5% of Americans, adults, experience clinically significant extreme ends of this spectrum. That's a lot more. 5% is a lot higher than a lot of other conditions that we commonly talk about. So I think it's an under-recognized thing. We don't know why. We can also look at hyperacusis, which is it's the name for a disorder where sounds are generally louder to you. It's not about patterns and it's not about context. It's not about oral or facial or this or that. It's just like everything sounds louder and is experienced like this. And we see this in kids, and it often kind of goes away, but about 20% of the population experiences this kind of hyperacusis-like phenomenon. So anyway, I don't want to take over this on this point, but just to say this is a common thing that is overlooked by us mental health focused people.
I have a question. Do you have do you see any difference between the patterns that were presented today by Colleen among the group of emerging adults in the category of gifted and talented? And would you offer any different recommendations from what you already did for that specific group? And he told me to choose a question, but I'm going to be a rebel and I'm going to ask my second question. We work in Head Start. What about emerging adults that are sandwiched between having a child themselves and having the support of their parents or lack of?
I don't know the data on gifted and talented. Do you? No, I don't know that. And again, like anecdotally, the sort of like increase in sense of like pressure, whether it's internal or external, is leading to a lot of problems and actually like underachievement. And so I don't know specifically data-wise, and gifted and talented kids are certainly not immune from the trends that are happening to everybody else.
Thinking some about the patterns that Colleen was talking about earlier and reflecting anecdotally on my clinical experience with the population you talked about, you're going to hear me get stuck on these polarities that Colleen was talking about earlier. I think in my clinical experience, I've seen a lot more trouble with anxiety in that particular population, and particularly a lot of troubles with higher standards for oneself and a lot of striving and perfectionism. Calling for additional attention to this balance of that first polarity that Colleen was talking about, which is really this idea of firm and compassionate, which is also what Colleen was talking about with this difficulty around accepting responsibility and attaining responsibility in that population, needing to do a little bit more fine-tuning because they tend to be on the too strict, holding themselves to too far of extremes. So that's a place to really emphasize a lot of the compassion, which is a great tee up for Kristen Neff coming right up.
And we, in the program that Kristen and I created, young adult multifamily groups, DBT skills groups, I think in the 4 years that we had that program running, we had like 2 total referrals for young people who had kids of their own. And so it is a blind spot in the literature. We are missing these folks in medical centers that they need support on both ends. They exist, they are out there, and they are not presenting to adult clinics for treatment for themselves.
I think maybe just reflecting on some of those people that we might see later down the lifespan as adults seeking treatment after their kids have left home and stuff. I think that there might be a perception that there isn't room to take care of their own needs at that time, and that might be part of that gap, as well as maybe some societal and medical collusion with that sort of neglectful stance. And I do think that there is a lot of kind of pining for what was lost in a time that was just such heavy exertion. And I would just put in a plug for thinking about that as like a stress condition related to trauma in the traumatic stress umbrella, and, you know, being a product of the demands exceeding the resources. And I think that we often get stuck on there's no way to reduce the demands, but there are often ways to increase the resources, and it might be a population that doesn't necessarily seek that out as actively for themselves as they do for their kids.
And the last thing that I'll add is I have had kind of like my Hallie example. I have had like 50, 60-year-olds who have emerging adults who have kids of their own. And so I am seeing the sort of grandparent trying to figure out like what would be appropriate parenting strategies right now for setting limits with my kid who has a kid. So we're seeing it intergenerationally. And I agree, we'll probably see them down the line.
I think I'm next. Just want to thank you for addressing this subject. I have a couple roles. I'm a daddy of 4 kids, to a blended marriage and family that all have these struggles. I think it's common. And as being a professor, that's what I want to bring up of social work. I read a long time ago when I was in this category, back in the Stone Age, a book by Kenneth Keniston called Committed Youth. And the whole premise of the book was based on a study he did during Vietnam War, where he found that young people in the age you're talking about had better physical and mental health indicators when they were activists. And he said it didn't even matter if they were against the war or for the war. And recently, working with the Environmental Humanities Department at the U, we found the same thing, that a lot of professors told us they were concerned about talking about climate crisis because they thought it would upset the students. And we found actually the opposite is true, that, that facing it and then feeling like I can do something about it was what matters. And I see you nodding, but you hadn't talked about that yet. And I'm wondering, if part of our responsibility as helpers, is to encourage people to become activists and be activists ourselves, because like all these studies have found, it doesn't matter if you actually change the world the way you think. If you feel like you can do something about it, it matters. So what do y'all think?
Yes, and pro. So some of that seems to be related to like sense of community or sense of meaning and purpose. So the it doesn't matter what you're involved in, get involved in something does actually seem to be protective. Again, fosters sort of that sense of belonging or sense of living a values-oriented life. So again, as helpers, thinking, again, openly, expansively about what we can do to support our young people finding their thing, whatever that thing is.
Yeah, I think this is a theme that we keep coming back to today, this idea for this, really any population across the lifespan, but especially this part of the lifespan where there's just endless transition and lots of hope and expectation for growth, right? The challenge is in our role as mental health practitioners and parents and supporters, et cetera, of this age range, is to help find this balance that is challenging enough for them to help them stretch and help them grow, protect them from the stuff that is truly overwhelming, that they cannot process, they cannot succeed in and grow in, but also the opposite side, right, of making sure that we're not shielding them and protecting them from things and making things too easy such that they don't have these opportunities for growth. So I think the example that you provided is a lovely example of how, right, difficult context and difficult information, right, for particular individuals who, right, that's the right balance for them, actually supports agency and growth, and I imagine other positive mental health outcomes.
I have a comment and a question that goes along with the emerging adult. I'm wondering if it's unique to Western civilizations as opposed to, for example, the country of Spain. We brought students there on study abroad for many years, and they would stay for extended periods of time in the homes. It wasn't necessarily a socio-economic decision where they would stay. But it was very, very common for the legality was 18 to be an adult, but they stayed in the homes till they were 30. I mean, nobody asked them if they were getting married or having kids, and over 30 was the age that they usually left home and got married. But I didn't see social services or mental health issues or many of the things that we speak of with the emerging adults here in Spain. And at first it took me off guard, but I didn't see a need for the services or even terminology that we use, as you gave your presentation, was very void there. So have you studied to see a comparison between Western cultures with emerging adults compared to places like countries in Spain, and what do you see there?
Yeah, so there are, and Arnett has people around the world, and so big studies out of like Japan, for example, there's tremendous financial instability, and young people aren't able to get jobs that sustain themselves, and because of like cultural norms in Japan, this is particularly problematic, and so it's this generation that people are trying to figure out what to do with emerging adults who don't know what to do with themselves without a job. And so I don't know about Spain specifically, but these little pockets where we have seen, like, is this a US thing, or is this like an Anglospheres thing, or is this around the world? At least post-COVID, it seems to be like around the world, the young people are disrupted in figuring stuff out.
I think we've got time for one last question in the back here. So.
What can young adults with minority identity intersections or who have experienced childhood trauma do to get the most out of their own mental health treatment?
Well, I think it's so important to talk about intersectionality, and I think there's a shift in this language that's really powerful that is very relevant to your question. And so in recent years, there's been a movement to use multiplicity as the context of having multiple identities that may have various associations with them. But intersectionality to mark the interlocking social oppressive forces that work against various identities. So that the idea is that when we speak of intersectionality, we are not speaking of Black, gay, woman, we are speaking of racism, heterosexism, gender as a source of disparity. And so I think that we can really refocus our attention from the experience of being marginalized by those forces to a concentration on the existing forces that provide that oppression. And I think this also links with the comment on activism, right? Like, there's a very different frame to say that's not inside of you. That is oppression that is acted upon you by social forces or social groups or whatever it is, right? And I think that if we as clinicians, we're trained to be very individually focused. And so that historical focus has made a lot of sense. And I think we actually are more empowering of our clients and patients if we can locate the responsibility for that in the problematic sources that produce it. And I think that actually engenders an interest in fighting against that that's really empowering for people who are in communities that have been marginalized and stigmatized. I think we always want to be acknowledging that we see that, we recognize that the world is not fair, there's a lot of disparity, there's huge problems in our in the way that we allocate resources socially and support socially, and it's a very important question, and I think that mental health providers can really be activists in their therapist seat if they can do some of this shifting from focusing on just what it's like to be marginalized to also what is producing that, while also, of course, attending to the experiences of traumatic stress that are associated with those experiences.
Awesome. Thank you, thank you, thank you. If we can, let's give them a big round of applause. you could see that we could go for hours, right, and keep doing this. So thank you so much for being here and being with us. We do have a gift for each of you. I didn't bring it up, but we do have a gift for each of you. So thank you so much. One more big round of applause. Thank you. So, so you're oriented. We'll break for lunch. If you've got a ticket, lunch will be just out here in the hall. Take that with you. They'll get you served. Come back in here. We have a pretty tight window. Do what you need to do. We'll start again at 12 o'clock with Dr. Kristen Neff. So thank you, everybody.